Welcome to the first European Symposium of Type-15Q syndrome. We are very happy that you could actually make it, and it's a great opportunity for us as patient organization, but also, researchers and clinicians to exchange, and that was the most important thing for me when I started my journey 8 years ago with my child that has Type-15Q with catastrophic epilepsy, and it took 8 months until she was actually diagnosed. I really wanted to change something, and here we are right now, changing the curves for our children, and thank you very much for coming.
Thank you, Verena, for organizing this, and I think that's a great opportunity to come together in Europe and to build up a very European international collaboration, and this what we have to do for the parents. So we have a REF program. I would ask all the presenters to go through their presentation quick, that we have time for discussion and exchange. And I will hand over for Sebastian, who will start the first session.
Hi, good morning, and also for me it's a pleasure to welcome you to the first DAP15Q symposium from Europe. And in the first session we have got exciting talks. We will get some experiences from outpatient clinics. We will also talk about registries, natural history data, and clinical endpoints, and we will also got the caregiver perspective. So now I'm happy to introduce Camilla Gabriel. She is talking about the clinical spectrum of the patients in the outpatients clinic of University Hospital Heidelberg.
Thank you. Hi, I'm Camilla Gabriel. I'm a European board certified genetic counselor, the only one in Germany still, so I have to still use that for the next few weeks. And I wanted to introduce you to our specialized Type-15Q clinic that we are running here in Heidelberg. So very quickly, because we don't have much time, the process to be part of our clinic is the following. The family contacts us. I gather all the relevant information, including the problems the families might have, and then I plan out a day. The days are individualized to the patient and to the family that's coming. We then give the family an appointment, and then the appointment day arrives, and they always see neurology, genetics, and our psychosocial team, and optionally they will be able to see epilepsy, social work, gastroenterology, physiotherapy. They might have an EEG with us. Almost all of them see speech and language. And then after a day with us, we then send them home and send them letters of recommendation for their treating physicians at home. They will then be able to come back to us, usually at a big point of change in their life. For example, when schooling begins or when they start puberty, that's when we would see them again, unless there's a new occurring problem, in which case they are obviously allowed to come back to us. We've now been running it for 2.5 years, and I wanted to give you a quick overview of what we've been doing. So our first patient was seen in October 2022. We've seen 35 families since. All of the families are seen by these two teams. I call it the clinical team, which is our neurologist and our clinical geneticist, and our psychosocial team, which is a psychologist and me. Most of them were seen by speech and language, which was more than we expected. But at the end of the day, fewer actually needed our epilepsy specialist, and that might be because our patient group skews young. So there will be patients that haven't developed epilepsy yet. We did 11 EEGs. Initially, we thought every child would need an EEG, but we've realized that many children have recent EEGs that we can just review either the findings or the raw data itself. The clinical day is between 3 and 7 hours long. We also offer, for example, psychology appointments for the siblings, if a sibling needs that. And we've been lucky that 100% of the families were willing to enroll in research studies, so we've been able to enroll our patients in a couple of different studies. The main parental concerns that the parents come to us is obviously development, especially behavior. And this worry increases significantly during puberty or in the prepubertal time, where the parents are noticing changes that make the behavior much more difficult, and obviously with a growing child, also much more difficult to handle. Sleep is a big topic. Many of the children have problems with their sleep and their sleep is not well managed by their team. Communication. A big topic is obviously the epilepsy with a particular fear of SUDEP. And then the question of therapies. Are the parents doing enough? That is the question that most of them come to us asking us if we think that. Some unexpected topics and patterns that we found was that we found that a number of our older teens or young adults developed sudden onset severe psychiatric illness, mostly in the form of schizophrenia or psychosis. These were patients that were well before this psychiatric illness began, most of them with interstitial duplication 15q and with rather moderate learning disabilities, but it may also be that those with very severe learning disabilities are not able to express the symptoms of the schizophrenia in the same way, and so we're not recognizing it as such. Something we've seen with our older patients, because we see children but we also see adults, is that we found that some of the adults had loss of the prior obtained faculties as they aged. The differential diagnosis, obviously the epileptic encephalopathy, but could also be psychiatric. And we have been genome testing those patients to see if there's a secondary finding, and so far we have not found that to be the case, so we do trace it back to the duplication 15q. We found that in our cohort of 35, the ability to learn language skews strongly female. Not all the girls speak, but many more than the boys, while most of the boys do not. And we've seen an extremely wide range of the severity of the symptoms, from children who have such strong hypotonia that they can't even lift their heads, to children who are functioning relatively well in school with some help. And we've seen this variation in both the ERIC group and the interstitial duplication group. So I think I've made it in my 5 minutes. I'm happy to discuss later on with you guys. I don't think we have time for questions right now, but we'll leave that to later. And I just wanted to thank our colleagues from the Children's Hospital and obviously the parents group who have been supporting us wonderfully. Thank you.
So keep your questions in mind. We will have time for discussion after the next talk, which is Karen de Hoys, who is sharing her clinical experiences from the Erasmus Medical Center in Rotterdam.
Thank you. This is yeah. I'm here on behalf of our DUP50Q team. Amy and Marie-Claire are going to talk later on too. And my two colleagues of the child psychiatry are in the back of the zaal. Well, I'm a pediatrician. I'm Karen de Heus. I'm a pediatrician specialized in syndromic care. And 15 years ago, we started a clinic for Angelman syndrome. And since there's a lot of similarity in the UBE3A issues, DUP15Q came along in interest, and we started this an expertise center in 2020. We're the only center in the Netherlands, and children visit us once a year or once every 2 years. And they're seen by a multidisciplinary team of pediatric neurologists, which is Dr. De Wit, a pediatrician, which is me. We have a behavioral therapist, which is a very needed person for a lot of parents. We have a speech therapist who is specialized in AAC, and a physical therapist. And we see the children every time they visit. And then at these special moments, like Kami said, like starting school, puberty hitting in, they are also seen for an extensive developmental and behavioral assessment by our child psychiatrist and psychologist. And our team is completed with our preclinical research team by the lab of Ipe Elgesma. We're an official national and European expertise center, and we're also connected with the ASF and the DUP15Q Alliance in the United States. We joined the clinical network meetings, and we have contact with the Letter database group. We do not have a parent organization yet, but there's a very active Facebook group, which Margot is leading, and well, we're looking forward to have it's officialized as a parent organization, because in our Angelman experience, we already noticed that it's so important to work together with parents to see where the needs are, but also to organize things together. It's well, we really need it. No pressure. when the children visit us, the usual suspects as themes are addressed by every member of our team for the epilepsy, the sleep, development, behavior, communication. Well, but also thinking with the parents together which school is or which daycare is suitable, which therapies are needed, information about trials and stuff. And we also, besides the information gathered through a questionnaire that we send in advance and history taking and physical examination, we also use a standardized battery of outcome measures for like communication. We use the communication matrix, and we have the C-builds to assess both the expressive and the receptive language development. Cindy, our speech therapist, she performs tests, AAC session to see what's possible and to help parents to explore that further in their daily life. Motor function tests, and the child psychiatry also has their own tests. So that makes us able to gather longitudinal prospective data about natural history of these children. At the end, we wrap up all this information in the letter to the parents, but also to the involved professionals in their local care setting, so they can, sort of translate it to their daily life. And we also gather this data in a database, so we can, gather a longitudinal information. That was it for this session. I come back.
Thank you very much. Are there any questions from the audience for the two speakers?
Thank you for both of the presentations, although I know one of you. I was interested in, because you said that there's a difference in ability to speak, and you see it skews to the female side. Do you see, for instance, regression in the ability to speak? Because sometimes we observe people, they kind of speak and then they lose the ability either through like autism spectrum or other reasons.
I think what we have been observing is that there's a lot of echolalia early on, and sometimes as that sort of regresses, as the free speech advances, which I think is established as a normal pattern for speech, that is quite common. And again, skews more in the girls and the boys that we saw. Many of them just don't have any words, and never had any words. But the girls tend to have this pattern of increased echolalia as they're younger, and then they sort of lose it, and then they start speaking in more independent sentences, which then seem less good because the echolalic sentences often are very long and complex, while the sentences that they come up with themselves might just be two-word sentences. But at least it is a freely constructed sentence.
Is this because epilepsy hits mainly boys, or even in girls with epilepsy, there is this difference?
Yeah, we see it independently of the epilepsy.
I was curious. You talk about siblings. I would like to know if there is also support, psychological support for parents.
Yeah, we try in our psychosocial part to discuss. In fact, we mostly discuss what the parents need to function better. That we feel like that is something that there is not well caught by the treating team. Most of the time, the children have perfectly good neurologists and even geneticists locally. What they don't have is this is someone who looks at the family as a whole, and that is what we found the families really needed when they came to us. So we do discuss exactly that. What do the parents need? How can we help them get to what they need? We found that most of the couples, for example, have very limited or no time to themselves. And so we discuss what are ways in which they could find small spaces of time for themselves or for them as a couple.
There's a question.
I just am very envious of the fact you have a team. How do you fund it? We can't get any funding for a team in a tertiary pediatric institution? That's my first question. The second one is, do you think we can continue to run individual genetic condition clinics? Is it relevant when all the issues for all the developmental disabilities that are genetically based are the same?
I'm going to pass this on to Maya, because this is her field of interest.
Yes, this very, very important question you addressed here. And to start with your first question, this is not funded. And this is all on top so far. And we tried to get some money, and we tried to get some structure to provide it on the long term. And your second point, I'm, as a geneticist, convinced that we need for every genetic condition something like a specialized appointments or clinics. And in Germany, I would say we can spread it over the country. Not every genetic department have to has for all conditions, but we can think about it to spread it through Europe, you know. And so I'm very convinced that, of course, we can provide a basis care. We discussed it yesterday, but the specific of these specific condition, genetic condition, we have to figure it out. We have to work it out, and we have to build registries, natural history study, and we have to think on treatment. You want to?
We don't have money either, but I think two things on this question. The first, the Angelman Clinic, we started with a starting funding from the parent organization, so we could set up the structure and everything. And because we already had this structure, it was more easy to fill in the DUP 15Q here, because we're the same team. And I think in Rotterdam we're very lucky that we have this cooperation among the genetics, the neurology, the pediatrics, the psychiatry. That's already a team, and different parts of the team see different syndromes. And we are lucky that our bosses see that this is important care. So we do this DUP 15Q clinic instead of that day another clinic on other patients, and we were allowed to do that, so we're sort of lucky. But I think this advocacy of the importance of seeing children is, I think that's the main thing, and parents can have a big role in that too.
Yeah, and while the clinic is not funded, the research is partly funded by the parent group. So that's important to say, that we have research studies that we have started, and that is mostly funded through the parents.
Good morning. My name is Sarah. I'm a parent from Canada, but not of this particular diagnosis. My kids are one of 3 families in the world, so I long for a community. What caught my attention was 100% of families are willing to engage in research. Are they a part of studies that are happening, in the clinics, in your organizations, or are they studies happening elsewhere? And are they initiating the studies, or are they joining in the studies, say, as a participant versus a partner?
A bit of all of that. So we offer international, and we had a European autism study, for example, running that most of the parents opted in, even though they knew that there would be no new findings for their own children. It was more for the bettering of the community. And then we have our own research studies that we have started here with a researcher, where we are looking at the region, for example, in a new way to try to better understand our patients and our patient population, if we can better see why some children develop better versus others who develop more slowly. So it's a bit of all of it. We try to have an open eye to other studies, nationally, internationally, that they can be part of, and introduce that to them.
I think this is one of the main one of the main reasons that it's so important to have an expertise center, because then you have all the children together and you can contact the parents when there are new developments all around the world that they can participate or not. Most parents in our country are also very interested in participating in trials, and also for the pharmaceutical companies, if they know that you have a cohort of well-descripted, well-known children with well-known used outcome measure, then it's also very interesting for them to have contact with you. But if there are only 3 in the world, then it's difficult. But then, even then, you can contact all the other parents and have a small natural history study, because natural history is the basis of everything.